Thank you. Go ahead.
All right, thank you. Thank you very much. Okay, I'm going to talk to you today about in silico clinical trial design, and I'll describe to you what that means, what role it plays within clinical trial design, and why is this something that should be interesting to you. I am going to start off by saying a little bit about what clinical trial simulation is not. There's a distrust in the general public when you say, I'm doing simulation. It means I've made a bunch of assumptions and I'm trying to predict something. So here's a couple examples that you might see in typical media. Here is a simulation on the left of a fight between Rocky Marciano and Muhammad Ali. They fought at very different times. They're thought to be two of the greats. So somebody created a computer fight between the two of them to predict what would happen. I think when people see that, oh, this is impossible, you know, the computer's making tons of assumptions, it's not real. But again, the idea behind the simulation is prediction. Another simulation of Super Bowl, that they use the Madden video game to predict what's going to happen in football games, to predict the outcome. Again, I think people reading this, oh, this is cute, but this isn't science, it's not important. You know, they wouldn't predict the same way as me. I think a general distrust. You also have situations like predicting the route of hurricanes, predicting weather. Maybe there's more trust to this in the setting, but again, the role of this is prediction of what's going to happen. I think we're inundated by simulations at this point. Almost all of them are in this role of predicting what's going to happen. So in clinical trials, we do see this. We see PK/PD scientists who are predicting what will happen when a drug goes into the body. Maybe they have a compartmental model which describes how it goes through, what will happen. Oh, this dose will create this effect. And it's a very important role, and it's fairly common. And again, they refer to these as simulations. It is very different than how we're going to use simulations in what I'll refer to as in silico designs. We're really not trying to predict the outcome of a design. We're going to use simulation much the way engineers use simulation in building airplanes. They use it for calculation. It allows the complex calculation of aspects that can't be done analytically. So you can't calculate analytically the lift to an airplane if you turn the flaps up at the very end. If we change the material, if we do different aspects, it's too complicated a system to do that analytically with a formula. So complex simulations are constructed that calculate the lift to the airplane, the drag of the airplane, how much weight can be a part of this. This is not used as a prediction per se, but more as calculation. We are going to do the same thing in thinking about a clinical trial design, where we are going to stress test it much like you stress test an airplane. And we're going to use it to calculate complex aspects that we can't calculate analytically within a design. And so this is purely a calculation tool. It's to do the complex mathematical calculation that we fail to do now using analytical formulas. And there's going to be a very interesting, I don't know if synergy is the right word, but comparison or contrast that happens here is that if you rely upon only mathematical formulas to calculate, say, the power of a trial, to calculate a sample size within a trial, you are restricting yourselves to very simple designs where you can calculate that analytically. What happens if the design gets more complex? The analytical formulas fail us. Now we need a complex tool to do the calculation. This is what simulation is used for. In essence, it's nothing more than glorified numerical integration, where we calculate the operating characteristics of a complex design. It now leads to several things. It allows us to test many different designs. It allows us to calculate the operating characteristics of very, very complex designs to enable us to do to figure out what design we want to do, the vetting of the design and the building of the design. So we put the design in software in silico to explore how well it works. So what does that look like? We can think of the design as the unit we are testing here. We're building an assay for the design, essentially, where we're interested in how well does that design work. So what we do is we create some assumptions about how well the drug works. And this is really what differentiates us from a prediction aspect, is we get to plug in the right answer. We say, suppose the null hypothesis is true, that all of the doses of this treatment are identical to the control. Then we can put it into the design and see what the design does, how well the design works. So we build software that pulls these patients in, runs the design, and calculates various performance characteristics of the design. What's the probability that we determine success in the trial, whatever success is? How many patients are used? How much drug is used? How long did the trial take? These aspects, which arms, which doses, which components of the treatment have been used, we can measure all of that to incredible details that can't be measured if you try to use analytical formulas. This, of course, leads to, well, I have many different measures of drug effect. I have many different accrual rates, which matter in the design. Dropout rates matter. The assumptions that go into the design, I can simulate many different assumptions, run it through my design, and measure how well does the design perform. How often does it get the right answer? Because I know, of course, the right answer in each assumption and what the trial should do, and I can measure that. And then I can use that as a feedback to my design and say, you know, I need to change the design because in some circumstances it's not working well. And then I can change my design. I can increase the sample size. I can change the number of arms. I can change the modeling of it, the patients enrolled. I can run through the design and vet the design as my measurement tool here so that over a wide range of scenarios it works really well. We can measure something like anticipated regret. How often do I get a result that I'll really regret at the end of the day? How often am I left in a gray area where we're not comfortable there and essentially the design didn't answer the question? We spent X amount of dollars, N number of patients, and we're no better off. These types of things we can measure in the simulation. And here, simulation is not prediction. It's used to measure how well my design works. And this is a little bit of art, a lot of science going into this part. It allows the vetting of the designs. Multiple designs are simulated for the exact same scenarios. I vary the truth in the number of scenarios, and I measure how well the design performs for whatever is important for that particular trial. whether it's selecting the right dose, selecting whether the treatment works, selecting the right dose to go to phase 3, whether I make the decision to go to phase 3, whatever it is you're trying to accomplish in the trial, I can measure through simulation. So let me show you some examples, and I'll go rather quickly through here. The role of some of these examples is not that you think that design that I'm presenting here is a great design. It's to show off how simulation played a role in the design building. Here is an example trial. Wow, that is not very clear. I don't know why it shows up as not very clear here. So I'll have to explain a little bit. I think the message comes across in this. What you're looking at here on the left is along the x-axis here is a measure of morbidity. Think about it as time in the hospital, time on organ support, something like that, a measure of morbidity. And the y-axis is actual mortality, an endpoint of mortality, where you're looking for a treatment that really is beneficial in both. And the endpoint here actually is a composite of both of these. What you see here is each one of these points is the result of a simulated trial. So if I focus on a single point here, right in here, this is a point that had a 5-unit increase. There's a bit of confidentiality here, so I'm not telling you exactly what the units are, but a 5-unit increase in morbidity, which is a good thing here. So both the going to the right is good and going up is good. Right here is the situation. This is 0, 0. This is 0 benefit. The treatment did exactly the same as the control. As you move up to the right, the treatment is performing better. Oh, you're not seeing my point. Sorry, my pointer. Thank you. This is the very black line that's going. I don't think I have a pointer. Maybe I do. I have a pointer. So that point is 0, 0. I'm going to say something about the colors. Okay, so that point 0, 0 is absolutely no benefit to the right on morbidity, no benefit on the y-axis of mortality. If that's the result of the trial, that point's black. That means it does not meet statistical superiority. That would be a failed trial at the end of the trial. And this is 1,800 patients at the end of the trial. That would be a failed outcome. Up here to the right, if I were to get an outcome right about here, I see positive morbidity and positive mortality, but not enough to be statistically significant. An observed positive benefit, but not statistical significance. If the point is green, it meets statistical superiority at the end of the trial. And so here, of course, there's very large morbidity benefit and there's very large mortality benefit. A point here would have large morbidity benefit and no mortality benefit, but still is statistically successful. Something here would have good mortality benefit, no morbidity benefit, but would be statistically superior and would meet success criteria at the end of the day. This provided already a great deal of visualization of the end result in the trial and what the scientific conclusion would be for different outcomes of morbidity and mortality. Over to here to the right, the bar chart, these are differing level of assumed benefit of the treatment. And so let's focus on the first 5 of them. The one on the left is a null hypothesis where in truth, there's no benefit. So the truth is this little point right there, but of course with variability in the data, you observe different things than that. The height of the green is the probability of seeing an outcome of statistical superiority, and that's about 2.5%. This second bar, there's a marginal benefit, a larger benefit, and here is where clinically we really want to show success, and this trial has about 91% power if we would run out to 1,800 patients. So it shows the probability of a successful outcome as a function of the treatment effect. And these last two are a couple different assumed truths there. What we were interested in is instituting futility earlier in the trial. So as I push forward, we are putting in a futility boundary early in the trial so that if there's a 1% chance of success by 1,800 patients or less, we're going to stop the trial for futility. What we did is we took all of the simulated trials by the end, and over here to the left is a mixture of all of these different scenarios. So some of these truths are really good treatment effect. Some of these are from the null. But at an earlier time point in the trial, up through about 500 patients, we instituted futility at this point. And what we did is any trial meeting futility, we turned pink. And you can see most of them are down here in the left where you're actually observing negative benefit in the trial. And these are trials that are stopped for futility, and they wanted to see what would be the final result of a trial that earlier stopped for futility. So these are the final outcome of what would happen if you didn't stop for futility. And then over here on the right, it shows how often the black stops for futility, and those would be failed trials. And they turn pink. That's a good thing. We stopped bad trials early for futility. You will see dark red over here for a trial that would have been successful but is stopped early for futility. So if we use now a 5% threshold for futility, you can see we're stopping many more trials that are pink, are down here, that would have been failed trials and meet clinical, thought that this really is a failed trial. We would not use that. You start to see several red dots over here, and you'll see a little sliver of red in here. It's very, very small, less than 1% chance that we stop what would have been a good trial at the end. There's only a couple in here among thousands of trials. And then as we move forward and we raise the threshold to say 1%, we're seeing more trials that would have been successful, but we stop for futility based on the threshold and what it does to our power and what it does to stopping trials that would eventually be failed anyway, which is a very good thing. And now we can start to look at what different thresholds do in this scenario. And then we decided we were going to use the 5% threshold, but we have a different decision point in this trial at 800 specifically. This is a phase 2-3 seamless trial, and at 800 there's a stronger futility stop. So we've already stopped everything in blue for futility, and then we have another futility threshold that happens at 800 patients. And we can look at different levels of futility and how often we're stopping bad trials and how often we're stopping eventually good trials. So if our threshold would be as high as 75%, we're taking and losing 25% of what would be successful trials in a scenario where the drug is really quite good, and you can see we're killing a lot of trials in this beneficial region. So now we can optimize the futility threshold in the trial through simulation and visualizing the end result. This is something you can't do analytically, but through this flight simulator, we can walk through the different places where futility can be used and view this and make better decisions about what the trial design is going to be and get predetermined futility rules for the DSMB to follow during the course of a trial. So this is a real simple circumstance of visualizing things that's much, much harder to do in any analytical sense. And so this was a tool that simulation allowed us to use within this particular trial. Again, we don't have to worry about the details of what the x-axis and y-axis is. I tried to give you some aspect of this, but this was a valuable process of simulation. And again, if you have questions, throw it up there on the chat. I can see that, and if some questions I may push off till later, but if you have questions during there, please shoot them out there. Here is an example of the ICECAP trial. This is a trial for the treatment of post-cardiac arrest. An individual suffers cardiac arrest, is revived in the field, brought into the hospital, and the thought is, and you probably all know the medical aspects much better than me, but as a statistician, I'll fight through it here, is that a lot of negative things happen through the stopping of blood to the brain. Heat can accentuate or exaggerate or make this worse. So the negative cascading sequence of things that happen by lack of blood to the brain is exaggerated by heat. So when the individual comes into the hospital, hypothermia is thought to be a beneficial therapeutic thing for these individuals for eventual neuro health. And so this is accepted in a number of places. This is standard of care. FDA has not approved hypothermia for therapeutic benefit. There still remains some questions about it, but big questions about how long do you cool. There's questions about temperature. How do you warm somebody? And so a number of aspects, and so there's a trial being planned, ICECAP, to explore this. And the original design was, and the biggest question for the team was the duration of cooling. And so the original design was, let's put 400 patients on 12 hours, 24 hours, and 48 hours of cooling, 400 patients on each, and then we'll figure out what is the optimal duration of cooling. Because cooling is thought to be beneficial, it was thought to be unethical, or is thought to be unethical, to randomize anybody to no cooling. So there is no arm here which is no cooling. So determining superiority of cooling can be difficult in this circumstance. So what we did is we originally simulated the trial that they had thought of, this fixed trial of 400 patients per these three durations. I've strategically placed several other possible durations on here, but you can see the three durations each. Sorry, my graph shows 300 patients on each one of these, and on 12, 24, and 48 hours. We simulate then this weighted score is a measure of neurological health at 90 days after the injury. And so think about a 1 as very good neurological health, 0 as very bad neurological health. This is a transformation of the modified Rankin score. And here could be a hypothetical outcome of the trial where at 12 hours you're seeing something, an estimate right here just below 6, 5.5 with a standard error. Then you see slightly better at 24 hours, slightly worse at 48 hours. And then we vetted, is this a good outcome? Or is there anticipated regret? Would this change medical practice? In some ways, this is almost the ideal outcome, that there's less benefit, you see benefit of cooling, and it's thought the longer you cool, if you go out far enough, it's bad. If you cool somebody for too long, it has negative consequences. So in some ways, this is almost the idealized outcome, but you can imagine that this looks like a straight line that then gets worse. that you could theorize that cooling doesn't benefit at all, but if you do it long enough, it's a bad thing. Well, what about 36 hours? Maybe that's quite a bit better and the curve continues up and then it goes down. Maybe it's flat over the whole scheme. If this were the result at the end of the trial, is this a good trial? And you can simulate a number of these circumstances and look at how successful the trial was. And there was a great deal of anticipated regret that, boy, I'd really like to see 36 hours. I'd like to see more patients here, many less at 48. I kind of regret I put 300 patients on an arm that started to look quite bad. Maybe I'd put some patients on 18. So we used that and said, okay, if we have anticipated regret, let's build an adaptive trial that as the trial progresses, let's put more and more patients on the arms in the area that start to look the best. So then we start to simulate an adaptive trial where the allocation to the duration changes. And here's actually a simulated trial that we shared with the team. The open circles are the observed rate at that particular dose, and we start at 12, 24, and 48, and then we start to adaptively randomize based on the efficacy outcomes to other arms. And here's the observed rate. This is a model-based estimate, the connected red dots. And then that is used to allocate the next group of patients, and that continues through the trial. That was the design we simulated. And when we showed the results to the team, they didn't love it. They actually disliked it. They thought that this response curve that was created was really impossible. That the curve can go up like this, it could level off, it could slowly increase, and it could eventually go down, but it's never going to go down and back up. That seems unrealistic. You're not going to have this where it goes down, back up. So they wanted the response model to be of a shape that was inverted U and it couldn't wiggle. It just was scientifically not reasonable. And maybe we would get better results because what they saw in the simulations are far too many patients out here when in fact it looks like it's getting worse. So the design wasn't doing appropriate things. It was performing poorly. They could see that in the flight simulator. So that led to unrealistic dose response curve. We changed the model. We changed it to a model that had to have a shape that had this inverted U. It couldn't be anything else. It could always increase over the entire range. It could always decrease. It could all be flat, or it could go up and then be flat, but it could never wiggle like the other one. And then in the simulation, they asked, well, we were going to do the trial in only one rhythm type. There are shockable and unshockable rhythms. Could we do this simultaneously with both rhythm types? So then we started to simulate both rhythm types and what would happen in the trial if we did that. And it was the iterative build of the trial design through the flight simulator that led to a trial design for this that actually had 10 durations of cooling rather than 3, used response adaptive randomization over the different durations. It enrolled 2 rhythm types rather than just 1, extending the results to a larger population. The final analysis, because of the duration response model, actually allowed the testing of whether there was a region of increase, which means that cooling works. So we were allowed to make a conclusion that cooling works through a dose response model and allowed selection of optimal duration. So here's what this looks like in simulation. I'm sorry, it's a bit sloppy in terms of the picture. Here's the first interim analysis where we enroll initially only 12, 24, and 48 hours. The duration response model is fit, and based on that fit, we then enroll patients into new arms, and this blue curve here is the probability of being enrolled to the new durations in the next period of time. So based on this, we're really very interested in the elbow. So we'd like more patients in this one on this rhythm type and a little bit longer duration in the second rhythm type because that looks like it's increasing throughout the whole range. We enroll more patients we collect more data. The model is being updated. You can see the model being updated. So at this point, we've enrolled, we've really focused in this region on this rhythm type. This is still thought to be the optimal duration. That's where new patients are going to be highly randomized to. We had special rules for opening up 60 and 72. Only when we really thought it necessary would they open up, or 6 hours, which was thought to be kind of small. The other duration the other rhythm type seems to be really searching, and now it's focusing on smaller ones, and this continues. In here, there's a bit of a jump from interim 12 to 25 to save a bit of time, and this goes on, and you can see this first one, because it really thinks this curve goes up and levels off, that it really focused around 24 and 30 hours. Huge proportion of patients in that region. This second one looked like it was going up, a little bit of leveling off. Now it really thinks it needs longer durations within this temperature. It opened up 60 and 72 in this simulated trial, and actually here's the truth that we used to simulate. 30 hours was optimal, huge proportion of patients in there, and the eventual conclusion was that that's the optimal duration at the end of the trial. In this particular trial, the optimal duration is 48 hours. We put the most patients there. It actually thought 60 hours was the best, so we missed by 1 in that case, but we put a lot of patients in that region. It took a while to get there. We can then measure over 5,000 trials, how often do we get the right answer? So in the circumstance where black is the truth, how often do we put patients on each of the durations? What is the dose that's selected as optimal in blue? So here it almost always picks 18, 24, or 30, which is a pretty good answer in this setting. And then we change the scenario to be a different circumstance. By the way, this is the probability of determining cooling is effective. So 96% chance we say, by the way, cooling works, even though we don't have a 0 arm. And then we can investigate that in a case where the cooling is negative. Where do we put patients? How often do we claim it works? And we can explore many different scenarios and vet the design, iterate the design. And so that was a process where the design was built entirely through simulation. Okay, again, I think it's an interesting trial. Part of this is there are some adaptive trials in here. But the role simulation plays in the vetting of a design. And the things you can get out of it are a lot richer than when you rely on calculating a power and a sample size and you're ready to run a design. It's sort of, for those of you who've done many of these, there are many trials that are run, and at the end you say, oh shoot, I wish I'd have done a different design. You can see that through the simulation. You can see that in looking at the operating characteristics, and invariably you start thinking about a designs that can evolve in certain situations. Let's see, 12:35 time-wise. David, I'll come back to that if you don't mind. Here's a quick example, and I'll show you this in part because this trial has been made public. We have another number of examples that are not public. This was a trial for a diabetes drug for Eli Lilly, a GLP-1 inhibitor for control of HbA1c, thought to be good in weight loss. The original design was going to do 3 doses and then run a phase 3 trial. So again, we started to simulate this. It was hard to pick a dose. Invariably, through iteration and iteration and iteration, we ended up with a 7-dose trial, seamless phase 2-3 trial, interim analyses every 2 weeks during the course of the phase 2 part, using response adaptive randomization on the 7 doses, where it was a combination, a utility function, a clinical utility index over change in HbA1c, weight loss, diastolic blood pressure, and heart rate. Of course, these last 2, if they were too high, it would say this dose has no value or is bad. And if it has a good HbA1c change, that's great. Lower HbA1c, and weight loss plays an important role in this as well. Is that if they were gaining weight, this would be something that nobody would ever use, and it would have low clinical value. We created a design where between 200 and 400, it did response adaptive randomization. It could trigger phase 3 and select a couple doses to go forward. And then it would, on Tuesday, it's running phase 2. On Wednesday, it's in phase 3. Seamlessly shifting entirely by an algorithm. Not a committee saying, oh, I think you should do this. It was an algorithm that was vetted through this extensive simulation process. Entirely prospectively planned, all by algorithm, all by rules and decision that had been vetted through a 9-month process of simulation. We're much better at it now, and we could do this in 6 weeks perhaps now, but the time this was built, it was certainly cutting edge. And so the trial has a burn-in period where we enroll patients on all 7 active arms. There was a placebo in green here, placebo in green, active comparator in blue, and then we start response adaptive randomization. At any point between 200 and 400, it could automatically jump to phase 3. It could select the doses to use, and when that shift happens, it spawns other phase 3 trials for the company using the doses that were selected by the algorithm. And then the phase 3 part looks rather like a fixed trial. But the sample size was created by the phase 2 part based on the effect sizes. Oh, here's how big the trial should be. So I'll jump forward a little bit. And again, this was built in Silico. We explored a wide range of accrual rates, missing data patterns, using exactly the primary analysis, exactly the dose response model for all 4 endpoints, the utility functions. It was all part of this software to simulate these. And again, we maximized the trial through the simulations. The trial ran billions and millions of times, and then the real trial was just the 3 millionth and first time, or however many were simulated. There's the saying that you don't want the time you run the trial to be the first time you've ever run it. You want to run it millions of times. And so we had run this trial, we had flight simulated it millions of times before the actual trial. The actual trial shifted at the first point it could. When 200 patients were enrolled, it said, wow, we've got our doses, we're ready to go. And it shifted to phase 3. The trial was very successful, which led to, I'll skip that part, which led to the approval of the drug in September of 2014 and forecasted to be a $1 billion drug by 2020. And what value did all of this have? We certainly did. We can't make the drug any better. The drug was a great drug, but the ability to seamlessly go to phase 3 in that, and it's probably clear that the dose was selected would never have been investigated in phase 2 in a 3-dose trial. So they may have taken a dose that was less effective and not as good and maybe not as safe as the one they were able to take because they did 7 doses. And they saw that in the simulation. When they only had 3 doses, there was a great deal of regret at the end of the trial, hence going from 3 to 7 doses. And it did speed up time of development, maybe a year, which may at the end of the patent life be worth $1 billion, which they decided to give to Berry Consultants. There's a joke there. I assume you got that. Okay. Ebola, of course, you're familiar with the outbreak of Ebola, and all of a sudden, we don't have clinical trials ready for this. Do we build a clinical trial with a single drug? Do we need combination therapy? Do we have time to do things the way we do it now in silos where we investigate a single drug? Is it effective? Okay, now we move on and we bring in another drug. Is it better? Is it effective? This seems to be the way we do drug development. We don't necessarily have time to do this. So the Gates Foundation was involved in building a platform trial, which is a trial where you build the infrastructure for the trial and then you bring in multiple agents to investigate simultaneously. Not only that, but they're going to combine combinations of any of the agents that come in. So here's an example where there are 4 agents. Now it might start with only 2, and then in the middle of the trial a third one is added. And the design knows exactly what to do with all the agents that come in. At some point it may spit an agent out because it's not good, and then it takes more agents in, so it's simultaneously exploring many agents and their two-way combinations. So if there are 4 agents in the trial, you can give agent 1 by itself, which is this dark green box, that's just 1 by itself. You could give agent 1 with agent 3 in combination, so there are 6 yellow combination therapies that could be given. So there are 10 arms in the trial initially. So we built the trial that would look at the efficacy of the 10 arms, start to give those arms or the combinations that are doing better more often, response adaptive randomization, and update continuously throughout the trial and add new regimens as they come in, and of course throw regimens out. Statistical model driving that, where it's built upon mortality. And I'll show you a simulation of this as well. And again, this is an example trial. It's one of the neat things about simulation is that you can show an example trial and they can look at that and say, yeah, that did what I think it should do, or oh, I don't like this or that, and then the design can morph to fit that, and then you can look at overall operating characteristics. Am I getting the right answer with high probability, with good use of resources, these types of aspects. So over here on the left are the new data that came in the last time period. Think of that as a week. We had 1 patient on every one of the arms. This is arm 1, arm 1 plus 2, 1 plus 3, 1 plus 4, 2, 2 plus 1, 2 plus 3, 2 plus 4, and so on, the 10 arms. Notice we had a failure, a death on 2 and 2 plus 3, and a success on all the other arms. That's all the data we have. So cumulative data, 100% failure rate on 2 and 2 plus 3, 0% failure rate on the other arms. Now the algorithm knows it's 0 out of 1 and 1 out of 1. Over here on the right is for each of the arms, the estimated probability of success is the blue line. The height of the bars is the confidence interval. You can see there's huge error here. We've got 10 total patients. The green dot is the probability that that arm is the optimal arm in the trial. Blue is the probability that that component is part of the optimal therapy. So the green ones are going to add to 1. The blue ones are going to add to more than 1 because 3 and 4 could be in the optimal therapy together actually. We then use these probabilities in green to randomize the next group of patients. So now there's an update. Here's the new data. We had a failure on 1 plus 2, 1 plus 3, and a failure on 3 by itself. Now we've got updated probabilities. It's actually really starting to like 4 with everything. 4 is looking great. So it wants to apply 4. There have been no failures with drug 4, so it wants to give more of 4. 3's okay, 2's okay, 1's doing okay. But this continues on, and you can see how often it gives the various therapies. And at this point in the trial, it's really liking 3 plus 4 is the best. That's the highest probability optimal therapy, and it's likely 3 and 4 are in the optimal therapy, and we're giving more and more patients to 3 and 4. We're kind of giving up on 2. It's had a high failure rate whenever it's part of the therapy, and the trial continues on, and at 250 patients in the trial, This is the end. Well, the trial doesn't necessarily end, but at 250 patients, here's the current set of data. We put a huge proportion of patients on the therapy 3 plus 4, the combination of 3 and 4. The black lines are the truth that I fed the algorithm. In the truth, 3 plus 4 is actually optimal. 3 is pretty good by itself, and 4 is pretty good by itself. So there's 4 and there's 3, where 1 and 2 have a 40% mortality rate. If you include 3, it drops to 30. If you include 4, it drops to 20. So 4 is the best. 3 plus 4 together is the unique optimal answer. And we put a huge number of patients on there. Here's the randomization to all the arms over the course of the 250 patients. And this arm right here is the randomization probability to 3 plus 4. And as the trial went on, we really wanted 3 plus 4. By the end, they're randomizing 75% of patients to that. The other patients are being given to 4. So it ends up randomizing 4 and 3 plus 4. The yellow line here is the probability that a patient enrolled in the trial at that period of time will die, will fail. In the beginning, it's about 30% because we're equally likely to the regimens. But as we start to learn the good regimens, that probability drops. And for a patient enrolled in the trial, by 250 patients, their mortality has gone from 30 to about 12% chance because of the arms that are being randomized at that period of time. Again, this complicated platform trial in Ebola was built entirely by simulation. Models dictating it, but you can't calculate the operating characteristics. How likely are you to pick 3 plus 4 in a complicated design without the simulation? It's hard to build the complicated design without seeing how well it works. So they work in synergy together. And I don't mean this only to be a tool in complicated design. You saw that very first design of futility where it was really bringing out a very simple aspect of a trial that was not terribly complicated to bring value to that as well. We can then explore how often, here's the exact scenario I just showed you a single trial from, and the truth of the probability of mortality in each case is shown in blue. Here's the 3 plus 4 that is optimal. The 10% mortality if you give 3 plus 4. If you give 4 by itself, it's 20%, or 4 with anything else, it's 20%. The number of circles here shows the average number of patients given to each therapy over the course of 250. It shows the probability of selecting that arm as optimal in black here. So 89% of the trials selected 3 plus 4 as the optimal therapy at the end of 250 patients. It shows over here what would have happened if you use fixed randomization. That was 81%. The average number of deaths over 250 patients in the adaptive platform was 49. If you used a fixed platform, just a different design, that was 70 patients. So the trial is more likely to get the right answer. And it's more likely to have less failures in the course of getting the right answer because, of course, it's putting many patients on the better treatments. And this can be seen, and we can vary the scenarios to a null and various scenarios into different cases and explore how well the design works under a wide range of scenarios. We won't focus on that so much. So far, pencil and paper to do analytical calculation. It restricts the design. Bringing in simulation allows you to visualize the trial, run many through flight simulator, envision it, but its most important role is the numerical integration. All those things calculated would be impossible to do any other way. It allows for more complicated design, more flexibility, better trials. So all of that kind of go hand in hand with simulation, which is needed in order to do this. So hopefully, why do simulations? These were the questions posed. To gain a better understanding of your design, to see the design in action, to limit anticipated regret, really see a flight simulator for it. How to do them, this is the harder part. It's a new science. It's building the software to do this. There are a number of packages out there that are available to simulate trials. It's an evolving science. Tends to be some expertise in doing simulations, but can be done on smaller levels as well with fairly simple coding. What to learn? Of course, the strengths and weaknesses of the design. Is there a better design? Is there anticipated regret in my design that I could design around and worry about it happening from the get-go, so I don't get done and say, oh shoot, it's the wrong design. We spent X amount of dollars, X amount of, or Y amount of years, and we didn't get the right answer. I wish we'd have done something else. That can be seen through simulations. All right, I will stop there and entertain any questions that I may not have gotten to. So David asks, you've shown us a couple of therapeutic trials examples. How much more complex would a simulation of a diagnostic strategy intervention be? Actually, in many ways, David, it would be easier. We've simulated a lot of trials of different diagnostics. And you simulate a patient coming in and they really do have the disease or they don't, or the characteristic, maybe a biomarker you're trying to find. And then you simulate where they really have it, and then what the test shows and how the trial progresses from there. We've built some flexible trials in that, but done some simulation within that as well. What are the ramifications if you're trying to find whether somebody is a pathogen positive patient? What are the ramifications to different entry criteria? What are the ramifications if only 3% are positive as opposed to 8%, and understanding the design. So it's very similar aspects of a diagnostic. How could you use simulation to help design a trial to identify a therapeutic window in which a time-sensitive intervention has been so suppose your therapy were a time from onset of injury, which may be an emergency room aspect. It may be a traumatic brain injury. It may be stroke. It may be some other aspect where it's critically important, like TPA, to get in there quickly. You can design your trial, and this is usually referred to as an enrichment trial. You could, first of all, simulate different entry criteria and simulate different factors and what the effective time from onset of injury is, to see what the weakness of the design may be. And then you could actually design the trial to have possible points in the trial where you change entry criteria. Rather than 8 hours or less, we'll go 4 hours. We've built trials where the time from onset of injury may dictate the treatment itself, which is a pretty complicated trial. So if the person is 6 to 8 hours, we're going to do A plus B. If they're 0 to 2 hours, we're going to do a different therapy. That's a much more complicated trial. But simulation, now you have to create the different assumptions of the truth, which can be fairly complicated. But that's a new area, and it's a personalized medicine, and it's just time from onset is like a biomarker in a sense. Health outcomes of a new diagnostic strategy. You could certainly simulate that aspect of it. Money spent depending on it. You could imagine mammography as a treatment aspect. Is this beneficial? How much does it cost to screen women in their 40s as opposed to a strategy of only women in their 50s? You may miss some cancers. You may not overdiagnose some cancers. The complication comes from trying to create scenarios about what are the ramifications of a missed positive, a false negative, a false positive, simulating hospital stay in different circumstances, mortality as a function of errors. So it starts to get pretty complicated when you start to use it, look at health outcomes, utilization aspects. But it's impossible to do analytically. It's impossible to do any other way but simulation. And once you start to build this, you can look at a design, simulate outcomes, and look at how well does the trial capture health outcomes. This is becoming a really hot area for PCORI, for embedded trials in usual healthcare. Simulation is a critical way in which seeing what effects things have within an embedded system. Do we use pilot data? Pilot data is wonderful. We find ourselves simulating data from patients where we don't have any data. We find ourselves building models to analyze data that we don't have yet, which you're uncomfortable as a statistician doing that. So I may have to simulate the process of weight loss, and I don't have any data on that, so we have to sort of get subjective views from the experts and build a model that we think represents that. To have pilot data to show what happens if it's in a diagnostic, some sensitivity, specificity, or anything there, or in the rate of MRS in cardiac arrest. There's a scale of ordered scale from 0 to 6. The rate of 0 to 1 to 2 to 3 to 4, maybe as a function of the NIH stroke scale. That's incredibly valuable to build a better simulation system of virtual patients, so that we have a much more realistic simulated trial to then build the optimal trial. We also take and simulate really funny pathological cases. Suppose the drug is killing people. What happens in the trial? Suppose it's different than the model we use. We simulate, when we use that model for ICECAP where it had to go up, flat, and down and couldn't wiggle, we simulated cases where the truth actually violated that to see how well the design would do when in fact truth is different. We want to build a trial that does well under a wide range of scenarios so we can simulate sort of pathological funny cases to make sure it functions pretty well under those as well. So pilot data is huge. Okay, so any additional questions, certainly send to the email address there. I'd be happy to respond to them. And thank you for your time.
Thank you very much, Dr. Berry, for a wonderful talk. Thank you for joining us, everyone. Our next webinar will be Friday, June 12th at noon Eastern, and it will be titled Writing a Great Protocol, Opportunities and Pitfalls for Clinical Project Managers. This will be for the Foundations track. Again, thank you everyone for joining us, and thanks to our speaker.